at the point where they need dialysis and transplant by the time they're diagnosed. And on account of this, you find that the outcomes are quite poor. And you find on account of that, as much as 87% of people in areas of the world where access is poor succumb within a month. This is not always the same. I mean, in areas where the resources are slightly better, you find that things are much better. The options for therapy include, of course, as you've heard, dialysis, kidney transplant, and conservative management. But we know without any doubt that kidney transplant confers the best possible quality of life. It reduces your risk of mortality, and in terms of cost savings, is the best management for you when you have kidney failure. It's an expensive procedure, but it's been available for so long. The first transplant was actually done 73 years ago in a set of twins in the US. It was between a set of twins, and one gave to his twin brother, and the twin who received the kidney actually lived for 20 years. It was well enough that he married the nurse looking after him and continued to survive. You've heard about disease donor transplants. This is something we should be looking towards. This is a clear example of the usefulness of this. A 6-year-old boy who had a disease donor transplant 53 years ago, and today is surviving with just that diseased kidney. So this is something that is now being done, as well as xenotransplants. You now have situations where pig kidneys are now being transplanted into humans successfully. And the hospital in the US where the first transplant was done is actually pioneering this. But despite all of this, you find that in Africa, we contribute a very low number in terms of numbers of kidney transplants. In the year 2021, the whole of Africa contributed only 1% to the kidney transplants that were carried out in different parts of the world. And the reason for this is not far-fetched. It's because, as I said at the beginning, we only have about 2% of GDP. The lower that you are in the GDP, the less your capacity to be able to provide transplant. You can almost draw a straight line graph between what your GDP is and your capacity to be able to provide kidney transplants. We know that there are 3 basic goals of healthcare delivery. You must keep your people healthy, you must treat the sick, but you must also protect families against financial ruin. So it is access, that's availability, affordability, and accessibility. And all this you can achieve through universal health coverage, which I'm glad, listening to the Chief Medical Officer earlier in the morning today, is something that Tanzania is proposing to begin. So transplant is available in different parts of our continent, and also in Tanzania, as we've listened to. But the factors determining if you get a transplant in Africa are based on a number of things. Which country you live in, what is the GDP of that country, do you live in the urban or in the rural area in that community? As you see, you're more likely to get a transplant if you're in the urban area. Do you have a renal care program in that country? And then does your national health insurance actually provide extended care to people with kidney problems? Your level of education, and also the number of trained nephrologists that you have. So if you look at the 10 richest countries in Africa, you'll find that they're also part of the 10 countries in which kidney transplants have been carried out. And this is a map of Africa, and as you can see, probably there. I'll need to update this because this number should now be 200 for Tanzania. One of the challenges is the number of personnel to manage this condition. And unlike what happens in the developed world, where in Western Europe you have about 30 nephrologists per million population, in most of Africa you don't have more than 1. And the little that we have are also being exported out. If you look at the top 10 countries where UK-registered doctors originally qualified from, you find that many countries in Africa are included. I'm glad to see that Tanzania is not on that list. In fact, in the US, when you look at the licensed physicians practicing nephrology. There are 1,400 nephrologists practicing in the US. 140 of those are actually Nigerians who trained in Nigeria and have gone to practice in the US. And meanwhile, in Nigeria, we only have about 230. So about half of our potential capacity is out there. In Nigeria, we've done over 2,000 transplants. Most of them are live donor transplants. We now do the donor nephrectomies both open and laparoscopically. There is some concern about commercial kidney donations, and I'll speak to that also. But you'll find that most of the hospitals are spread between both public and private hospitals. This is a list of all the hospitals currently in Nigeria where transplants are being done. And what you find is that in my country, the privately run hospitals tend to run better. And I'm honestly quite impressed with what happens here in Tanzania, where the public hospitals seem to be at the forefront. But you find that for you to be successful, the center must be in a place where it's highly populated, enlightened, and economically endowed. Usually you need an empathetic, focused, innovative, and motivated individual as a driving force, and I've seen that at the hospital here in Tanzania. And then must have the backings of the authorities. For the CMD to be here, and the CMO to have spent the better part of the morning here, I know you have all the support that you require. Specifically at St. Nicholas, we've also collaborated with many institutions, and I would advise that you continue to do that. Yes, you can do it independently, but in the innovative aspects of transplant care, it's also important that you have collaborators. We have collaborated with institutions in the UK, in India, and in the US. The youngest we have transplanted is an 11-year-old. The oldest has been a 16-year-old. And as with most other countries in our part of the world, the mean age has been about 45 years. More male than female, and these are the numbers we've done over the years. Currently, we transplant between about 30 to 50 patients, more male than female, very young age. Donors, of course, cannot be younger than 18, and usually not older than 65, but we've gone as high as 70 in some instances. And we try to ensure that the donors and the recipients are closely related. And we have, as you get to know, the need for you to ensure that there's no commercialization involved in the act of transplant. The Declaration of Istanbul actually asks that we should take measures to protect the poorest and vulnerable, and not ensure that we use the poor and vulnerable as potential donors. We have an act in Nigeria. I'm glad to hear that the Tanzanian act is soon to come. But I think I need to speak a bit to the funding challenges that you have, because we know that that is the major challenge that is impeding the growth of transplantation in our continent. While government donations and employers offer some support, they fall short of meeting the significant needs. So here are some novel areas that I feel might help to improve access. One you've already spoken about, which essentially is to expand national health insurance to make sure that this also covers the provision of care to patients with end-stage renal disease. But also to develop some innovative public-private partnerships. You can get your private sector capital to leverage on modernizing. Just get one of them to say, look, you provide the capacity for us to be able to do our HLA and cross-match locally. And of course, you'll be given some tax relief for that. So banks can do that. Telecommunications, we all tend to, be quite successful in terms of the profits that they make, are things that you could consider making such collaborations with. Then NGOs. By now, you should have a transplant-focused foundation. And this has a way of leveraging on advocacy and leveraging on fund acquisition to make sure that you have financial assistance to patients and families. And then utilize crowdfunding platforms strategically. And then we have a very strong diaspora population in Nigeria. I'm sure you probably have the same. Get them to get involved and use them to also be crucial source of investment in your health sector. But you must also improve regulations and infrastructure. You must ensure that your legal framework is established to protect not just the patients, but even those that are practicing, the act of transplantation. Leverage on digital health interventions. It can be used to track your patients. It can be used to track investments, and it can also be used to ensure that you keep track of the patients. You can have targeted taxes and levies. You can have sin-led taxes, and specifically earmark that to provide care for patients with kidney disease. These can be taxes on tobacco, alcohol, or use of mobile phone. These are ways the government can say 1% will be devoted to renal care. And then, of course, strengthen ethical and legal frameworks. And also importantly, as has been said, invest in training and capacity building. And before that, also, have at the back of your mind that not only should you do live donor transplants, you should also start planning the possibility of establishing a diseased donor program. And this would involve enacting the appropriate legislation, increasing public awareness, cooperate with the various ICUs from which potentially the diseased donors can come from. There has to be collaboration between centers, and there has to be the public enlightenment. So I usually leave with this slide. This is one of our earliest transplants done 25 years ago, where the husband donated to his wife, and both of them are still alive and well. Thank you very much.
Thank you, Professor. You can just have your seat, then later we'll come for just here, you can have your seat down on then once we finish all the talks, we shall come up for the plenary discussion. Thank you very much. I can say you are deliberating on what we discussed, on what we decided in March in Yokohama about making sure that we train our people in Africa, and that's why you are here, so that we can continue supporting our programs. Let me take this time to welcome our second speaker, Dr. Kesi Shija, who to me, we have been working with him ever since we started this program of kidney transplant. Today we are celebrating 10 years of Benjamin Mkapa. Dr. Shija was there when we were trying to do the artificial insemination so that we can start nurturing this baby. And now today we are seeing the fruits of the work that he has been doing. He's known to us as a consultant nephrologist, and he's one among the pioneers who are able to come up with this program from day one to today that we are celebrating this day here. Karibu sana, Dr. Shija.
Thank you so much, Dr. Meremo, for inviting me to have a talk on transplant at this very important moment of first organ transplant symposium here at Dodoma. Let me take this opportunity, first and foremost, to thank the Benjamin Mkapa management for organizing this very important symposium, which enlightens and invites blood and also local, where we can share as scientists the experiences from across the globe. We have guests from across the continent and also from Europe and as well as from Japan. So we
Sorry for the short delay because the version of the PowerPoint presentation we have is not supported by this computer, so we're getting another version. Sorry for the short delay.
As other colleagues have said about the challenges of kidney transplant, I mean, the CKD is still a global problem. Of course, Africa as well as global, and the burden has been increasing on recent years because of the increase in non-communicable diseases. It was reported that in 2021, there were centers are very few, and the second one, Nigeria also is among the leading countries which have some centers. And these are due to several factors, as Dr. Ebuna has said. One of it is poverty, and the other one is financing the kidney transplant services. We know it is among the expensive services, but we are still having some challenges with the logistics. We know we cannot afford to get immunosuppressants because we are limited with some pharmaceutics. Therefore, people cannot afford because the limited accessibility of the immunosuppressants and other diagnostic services. So, kidney transplant at Benjamin Mkapa Hospital started in 2016. We know before 2017, in our country, all of the patients were referred abroad, and we thank the government commitment where enabled us to start kidney transplant, and the Muhimbili National started in 2017, and we followed up in 2018 March. So this has a lot of transformation in health quality of life of our patients because of the accessibility of the services. At Benjamin Mkapa is working with the University of Dodoma. We have a long history of establishing these services because of the long history of collaborations from Tokoshkai Medical Group by the government of Tanzania. In 2003, the government of Tanzania had an MOU with Tokoshkai Medical Group to strengthen the health services in the country. And in 2010, Tokoshkai donated the hemodialysis machine at the University of Dodoma. And when they came in 2016 to see the progress of the hemodialysis services, our leaders had a meeting with them to request for enabling to start kidney transplant. And there now our journey started in 2016. So the initial activity which we were to do was to do situational analysis, and the situational analysis were performed at Benjamin Mkapa Hospitals, where we scored about 60% of the available infrastructure that can enable kidney transplantations. The remaining were to improve after the assessment. So the Tokoshkai Medical Group, which was led by Professor Kobayashi, had a commitment, and they declared that kidney transplant can be performed at Benjamin Mkapa Hospital. And then now we started several phases of preparations, where we started in 2017 up to 2018 by training, infrastructure improvement, and covering all the logistics which were missing. And then now we started kidney transplant, the first one which happened in 2018 March. From there, we continued with them for the next 4 years, and our local team started kidney transplant in 2020. So how did you afford to start kidney transplant? Because of the training and the infrastructure improvement, but very important is human resource development. When we started the kidney transplant, we have some expertise which take over the kidney transplant after our mentors left the project. So you can see the distribution of the human resources. As our colleague said, it is a multidisciplinary approach services, which is very important, key for the kidney transplant. It involves a lot of expertise. So our kidney transplant services protocols, we have, of course, pre-transplant wake-up, but very important is the address the immunosuppression to prevent rejections. So we use immunosuppression protocols, which includes, of course, the maintenance immunosuppressions and the induction immunosuppressions, but also because of some of our patients have some risks, we had also to do desensitization, where we use protocols like, of course, desensitization by giving rituximab, as well as performing plasma exchange for a high-risk group. So after these preparations, we are able now to analyze our data, where last year we published our work through the title of Kidney Transplant in Low Resource Countries, and these are some of the findings. So if you look on our data, basically the common causes of CKD is hypertension and diabetes. And if you look of the predominant group is mainly, as you can also appreciate from other studies, that commonly the transplanted people are male, and because also even if you look for the risk factors of the CKD, male are more affected as compared to female. And because of some individuals we found they have some risks here, therefore we assessed and then we do kidney transplant for moderate high-risk population, like donor-specific antibody positive individuals, where we introduce our desensitization protocols. And our results equally the same as from Europe and the other developed countries, where our patient survival rate of 1 year, 3 years, and 5 years are equally the same as other published data. as well as the graft survival, almost the same as other countries. So what have we achieved on this celebration of kidney transplant? First is we have increased our accessibilities of Tanzanian citizens where first we were to get kidney transplant abroad, but now they can get along their proximities. But also we have spent some funds from the government because of reduction of the abroad referrals. Of course, when you give a kidney transplant to a patient, overall quality of life become enhanced, and therefore the individuals become productive, and at individual level, even at the community levels, and they become work power to the communities. But also, we started the kidney transplant. We invite kidney transplant for patients who are nearby countries where they don't have these services. So we expect in the future Benjamin Mkapa also to be a hub for transplantation services, training and research. And this is because currently we are constructing a center which we are collaborating with Tokoshkai University of Dodoma. This will be a center for kidney transplant training as well as research. So we invite our colleagues from nearby countries where the kidney transplant is not performed. And we think through these collaborations, the gap of kidney transplant in Africa will be resolved. Thank you so much.
Thank you very much, Dr. Shija. And because I'm standing for the first time, I would also like, on behalf of Muhimbili National Hospital, to really congratulate Professor Abel Makubi and your team at for commemorating your 10th anniversary this year. And also for opening up this very important conversation on organ transplantation in the country. When I was listening to Dr. Shija, thank you very much for taking us Len. He started talking that the preparation started in 2016. That's almost the time that BMH was starting to be in service, which means the hospital really hit the ground run and not stopped 10 years along the line. This is what medical fraternity is supposed to be if you want to be relevant. Now we are changing gears a bit and we are going to bone marrow. And with this, I would like to welcome Dr. Stella Wenslaus Malage, who is going to take us through the experience of bone marrow transplant for sickle cell disease at BMH. Dr. Stella is a hematologist and assistant director of hematology, oncology, and nuclear medicine at Benjamin Mkapa Hospital. She's also a faculty member at University of Dodoma. And Stella, please take it away.
Thank you very much for a kind introduction. And I'm going to share with you generally a response to sickle cell disease burden in Tanzania, how it was transformed from the non-curative therapy to curative therapy. So concerning the burden, this has been explained, and it is very well understood that sickle cell disease is very common, not rare anymore, and actually it's a national emergency condition. And it is estimated that by 2050, almost 14 million children will be born with sickle cell disease. And what is striking is that majority of these births will be in Africa. And what again is not is striking is the survival limitation to as below as 10%. And following this epidemiological burden, Tanzania responded very well by first decentralization of service, where almost all Tanzanian regions, sickle cell disease have been integrated into district and referral hospitals. But again, accessibility to hydroxyurea has been promoted. However, the accessibility is still limited to as below as 12%. Also, the government has strengthened the workforce. Almost 500 clinicians have been trained. And again, promotion of early case identification by newborn screening. But understanding that not all patients are covered by this type of intervention, the government of Tanzania, in collaboration with the government of Italy through Benjamin Mkapa Hospital and University of Dodoma, in 2018, started a development program primarily to set a first transplant center for sickle cell disease so as could offer curative therapy to patients who are in need. So preparations took almost 4 years, and the main activities that were done was to conduct capacity building to local team, both virtually and in Italy, but again, improvement of infrastructure, including lab, pharmacy, and blood bank. And in February 2023, we were able to start our program, and for that very first year, we were able to transplant 9 hematopoietic, 9 sickle cell disease patients, and by April this year, we have been able to transplant a total of 30 children with sickle cell disease, 29 being a matched sibling donor, and the other one being stem cell reinfusion due to graft failure. So later we are going to hear from our colleagues in the blood bank. So this is also one of the important aspects once considering curative therapy, blood bank consideration. So this was also considered, and most of our patients had to receive automated red cell exchange, at least 2 to 3 sessions, so as to have the smooth journey while receiving transplant. And for our patients, we considered matched sibling donor, and we used standard myeloablative conditioning comprising of busulfan, cyclophosphamide, ATG, rituximab, and methotrexate and cyclosporine as GVHD prophylaxis. And standard antimicrobial prophylaxis and anti-seizure were considered, and the normal oral nutrition was provided. So this is quite a busy table, but I want you to focus on very few things. So from February 2023 to April 2026, as I've said, 29 matched sibling donor patients with a sickle cell disease were transplanted. To date, 27 have engrafted, 24. However, for this presentation, only 24 patients' results will be shared. So we have been able to follow up our patients to almost 20 months, and we have had quite interesting results that are comparable to centers that have experience in transplant. So the overall survival is around 96.7%, close to 97%. We experienced one post-transplant complication mortality. So one patient is gone. And in this cohort, again, we were able to transplant 3 patients with ABO mismatch groups, and they are all doing very well. And looking at the infection pattern, we have noted quite an interesting endemic infection risk. We had quite significant number of patients who had a relapsed Mycobacterium infection, but again, there are those who had malaria infection. So this is also an important part of making a follow-up in our setting, try to understand if at all we need to provide prophylaxis to these very specific infections. So coming to graft versus host disease, it is still manageable. However, we are on the slightly higher end, but we think it's due to some limitation of available medication. But what is, again, very promising is that to date we have 0 patient with a sickle-related event in our cohort. So of the 29 patients who are matched sibling donor, 26 are symptomatic and 3 have just been transplanted. 11 have already stopped immunosuppression and are going back to school. And what again is encouraging is that a majority of these transplants after some time were done by local team, almost 22 transplants. So hematopoietic stem cell is feasible in our country, in our setting. However, it requires minimal investment in infrastructure. Adequate human resources and training is something to consider, and committed administration and financial support is of paramount importance. We are having ongoing collaboration still with our colleagues from Italy, but together with other experts from different parts of the world, we tend to have weekly multidisciplinary team meetings discussing challenging cases. And we are very happy that we have been receiving benchmarking visits from our colleagues who are to start transplant and inside and outside of the country. So there are some few challenges, mostly clinical. As I've said, there is a limitation of chronic post-transplant complication treatment, but a bit of endemic infectious risk, and a bit of limitation of knowledge to our colleagues who are not very well informed on the transplant protocols. But again, there are some structural challenges, including drug availability. Somehow, somewhere, we experience blood shortage, and again, a limitation of infrastructure. For example, one of the goals that we want to achieve is to expand the capacity of transplantation at any time T from 3 patients admitted to 6 patients admitted. That will assist in promoting accessibility of transplant timely to our patients. But the most striking one is the financial challenge. These procedures are costly, and majority of the insurance companies are not covering. So it's an area where we need to look at. So going to the future, we all understand that this has been a government-funded program, but sustainability is still a little bit uncertain, and affordable care depends on reliable supplies, cost analysis, and trained, motivated staffs. And our priority as a center is to expand to new indications, and again, formation of regional-wide bone marrow transplant network. So this is the end, and I would like to thank Benjamin Mkapa Hospital Administration, fellow colleagues, children and families of those patients that trusted us with their lives, University of Dodoma, Help 3, San Gerardo Hospital, and San Rafaele, and all other parties that contributed to this. Thank you very much.
Thank you very much, Dr. Stella, for that very insightful talk. I think while we continue to listen, I know there will be a number of them. Please put your questions. We'll have a good discussion at the end. Just to reiterate what Stella was also saying about reliable supplies, I think everybody has been talking about that, so it will be a nice thing to discuss once we come to Q&A. Our next presentation will be coming from a team from MNH, also talking about their experiences in organ transplant. I think in the interest of time, they fused their presentation into one. It was kidney and bone marrow. One of you is going to present on behalf of MNH. Dr. Jacqueline, are you presenting? Yeah, Dr. Jacqueline Shaw, but Dr. Helen, I think you need to be recognized for contributing. Dr. Helen President, she's a specialist hematologist. So in the interest of time, we decided to have one presentation which will be presented by Dr. Shaw. And Dr. Shaw is a consultant kidney transplant physician. She has been a pioneer when we started this initiative way back in 2017. Karibu.
Asante, good afternoon, everyone. Thank you very much for a very kind presentation. So my presentation, as introduced, I'm coming from Muhimbili National Hospital, and we have two centers at Muhimbili. We have the main hospital, that is Upanga, on your right, and the left is Mloganzila branch. Both centers are centers with kidney transplantation, and Mloganzila is a center where we perform our bone marrow transplantation. Muhimbili National Hospital has a capacity bed of 1,500, and Mloganzila has 656 beds. Both hospitals also have dialysis units, with Muhimbili having about 400 patients, with more than 48 dialysis chairs, and Mloganzila we have 12 dialysis chairs. So the burden of kidney disease has been told by many of our presenters. The chronic kidney disease, we understand it's a major burden in the whole global. Worldwide, it's said that the current data is saying 14% of adults more than 20 years of age are affected by CKD. And in Tanzania, this is 7%. And as the previous speaker said, we have hypertension, we have diabetes, but 50%, almost 50% of our CKD patients, the cause is unknown. This tells us that we need to investigate. And so in Tanzania, kidney disease affects younger people, those of less than 40 years of age, and about more than 3,000 patients are on maintenance hemodialysis, and many of these are transplantable, being young and energetic. So in Tanzania, this NCD is a major cause of many illnesses. Renal failure is there, and 2.8 of our population is mortality is caused by renal failure, and liver cirrhosis contributes about 5.9. So in developing our nephrology services, we have, because of the big burden, we had a paper written by our team, and here we are talking about how to improve the kidney disease in Tanzania. And it has been said in the morning that we had to improve our care by increasing dialysis units. Currently, we have 70 dialysis units in Tanzania, Muhimbili National Hospital being the largest. And we have 400 patients on dialysis. In Tanzania, we are only 40 nephrologists. This is very little. And we have renal nurses, renal specialist nurses. There are now 30 in the country. And 3 centers of transplant are available in Tanzania. So the road towards transplantation at Muhimbili National Hospital, like most of our presentations that have been said by previous speakers, we depended on collaboration with experts from abroad. For us, we had a BLK center in India that worked with us in preparation from the training of staff for 3 months till time when we came and prepared our own standard operating procedures, having our transplant legal document, and then in November 2017 we had our first transplantation done. So all transplantation in a hospital are guided by hospital regulations. This is very important, as it has been said, to avoid organ trafficking. So this was our first transplantation, and we published a paper telling the whole world, and it's because we are the 8th country in Africa to start this program. So how we've been doing? So after starting transplantation in 2017, then we expanded our transplantation program to our pediatric population. We started with adults, and in 2019 we started pediatric transplantation. We started with a 9-year-old boy, and is now doing very well. Then we expanded our services to Mloganzila, where we are transplanting there, and mainly we are doing their laparoscopic surgeries. So in the photo here, we have our Professor Mseru, who was the key person pioneering transplantation in Tanzania, establishing the first transplant in Tanzania. So initially, we were depending on experts from abroad, but currently we are performing transplantation by our own local team. The outcome of our patient is good. Survival of the patient is 90%, 91%. Graft survival is 96%, which is very much accepted as in other countries. So this is a pediatric patient who was transplanted at 9 years, and currently he is 16 years old boy and in a secondary school. Our goal is we have performed 124 kidney transplant, but our goal is to make transplantation at Muhimbili a routine procedure where it's not done by KEMS, so it should be incorporated in daily routine. Other transplants that we perform at Muhimbili National Hospital include bone marrow transplantation. We have done 16 bone marrow transplantation, and mainly we do the multiple myeloma cases doing autologous transplantation. So the first one was in November 2021, and the recent was in 2024. 5 patients were transplanted, and there is a paper also to document what we have done with a very good outcome. Progression-free survival was 100%, and at 1 year, all patients were alive. Another program is cornea transplantation. This was a program that existed until early 1990s, but it then stopped because we did not have the law that permitted availability of cornea from diseased people. And we don't have a cornea bank, so we used to depend on donors to support us, but then later it came short and we could not continue. So now we are preparing a team. We have specialists who are going to be trained for the same purpose, and we are preparing to invest to have our own cornea bank and then restart the program. We understand the need that 20% of our patients attending our clinics have corneal opacity that requires cornea transplantation. Another big program that we are going to start is liver transplant. We have 5,000 people with liver disease, and these will require transplantation. However, we were supposed to start in 2025, but our team that was trained, due to COVID, the training was shortened, and then now we are retraining. We are improving our infrastructure. We're in the last stages. We have 50 patients waiting for transplantation, and we have patients that have been transplanted abroad that we are following up, taking care of them so that the team is will be capable of taking care of the transplanted patients. So we know that there are many barriers in transplantation. Generally, high cost is the major, as it has been said before, and the cost of transplant is high because we depend on consumables and medications from abroad. So another one is specialist shortage. This was even discussed in the morning. The number of nephrologists and transplant surgeons in many centers is 1, 2, 3, 5. So we cannot have big teams and make more transplantations. Cultural beliefs and weak legal frames have been discussed before. We need transplant law that will allow us to expand our donor criteria. We need transplant law to avoid human trafficking. So this is a paper that we are going to publish soon. It is discussing about how to improve transplantation. Only way we can afford transplantation for every patient who needs transplant in Tanzania is to make sure that we increase the numbers and we lower the cost of immunosuppression. Another sustaining the programs, we need to build our capacity. We need multidisciplinary team training, ongoing mentorship, local autonomy, and infrastructures need to be upgraded. We need a registry for our country. At the National Hospital, we have a transplant registry for kidney, for bone marrow, but these are to be united to have one large transplant for the whole nation. It helps in improving the quality of transplantation, policy planning, ethical oversight, and research. So in conclusion, a feasible pathway forward for successful transplantation. The National Hospital national hospital journeys in transplantation demonstrate that even in low resource setting, establishing and sustaining complex medical services is achievable with dedication and strategic partnerships. The key takeaways is that we need to dedicate in capacity building, we need strategic partnerships, sustainable investment, and we call for policymakers, funders, and healthcare stakeholders to support us in this. Thank you very much.
Thank you, Dr. Shaw. That's why in nephrology sort of Tanzania, we call you Iron Lady. She has been able to summarize cornea, kidney, liver in 10 minutes. Please, Dr. Faraja, convey our congratulations to the Executive Director of MNH as well as MUAS. We know that Muhimbili has been the premier of healthcare, but you can see your birthday boy is coming up quickly. So you must keep up running. If you are not running, then the birthday boy will overpass it. Yeah, so you must know that the birthday boy is coming very aggressively. So it's my pleasure to welcome our last speaker for this session, who is none other than Dr. Lillian, who is coming to us from the KSMC, Kilimanjaro Christian Medical Center. She's a specialist who is a hematologist and has experience on blood transfusion. And also she is coming to us to try and show us what they are doing so as they can also start a center for blood and bone marrow transplants. Karibu.
Thank you very much. Good afternoon, everyone. I'm here to share our experience on setting up a bone marrow transplant in the northern zone. Our journey will be very short because Benjamin Mkapa have opened the way and we're just like catching up. So starting with the burden of sickle cell, as most of the presenters have mentioned, in the global, 300,000 babies are born yearly with sickle cell disease, and majority of these patients are in sub-Saharan Africa, where Tanzania is among the top 5 countries that have a higher burden of sickle cell disease. If you compare the 5-year survival between the high-income country and low-income country like Tanzania, it is 95% versus less than 10%. This makes bone marrow transplant a necessity and not an elective procedure. So there is a map on your right side. This map was published in 2018, and it was a summary from the first World Bone and Blood Transplant, and it depicts that by 2018, only 6 countries in Africa had access to transplant services. But we are here today changing this map by adding Tanzania with 3 centers who will be able to provide transplant services. And as you've heard, Benjamin Mkapa have done 30 transplants for sickle cell patients, and I know there's some other transplants which were done for multiple myeloma and lymphoma patients from Muhimbili National Hospital. So this is our map on how we are going to start our transplant. The whole initiative started as early as 2023, and we started with the establishment of dedicated sickle cell clinic. As you know, majority of these patients are being attended in the general clinic, like pediatric clinic or internal medicine for the adult. So we started by creating a sickle cell and hemophilia clinic to optimize care for this patient. And then we went on and started a database which give us a clue, and it guides us to see what's the burden and how we can easily tackle this challenge these patients are facing. One of the challenges was also the access to hydroxyurea, but we thank the Ministry of Health through MSD, but also our partners, where now we have been able to provide hydroxyurea without cost for most of our patients. We started with less than 5 years of age, but now we are happy to provide even for the adult, and this is free of cost. We then start to build a team, a bone marrow transplant team. This included the nurses, laboratory technician, the social welfare administration. The whole team include multiple people, and each personnel play a big role into forming a good transplant team. And then we went on and identified patients from our database. It was very easy because we had already a database which existed, so it was easier for us to see who are the best candidates for transplant. We went on and started renovation of the existing ward, and initially we wanted to construct a new transplant unit. However, because of shortage of infrastructure, we end up renovating the existing ward to make it suitable for the transplant service. And the theme behind is to do a simple and less costly but effective transplant unit. Another biggest milestone to this project is the opening of the radiation center at KSMC. This have made us to be able to get irradiated blood product on ground. One of the biggest challenge was getting available irradiated blood product. So the opening of the radiation center ensured that the blood supply will be easier. And because before the opening, we thought of maybe should we transfer this product to either Ocean Road or Benjamin for irradiation. But now we can have irradiated blood product on ground. Another milestone was the HLA typing. From the patient group we identified, we started with the 10 patients for HLA typing. And among these 10 patients, we have 5 patients who are fully matched and ready to start transplant. The 3 patients were half matched, and this we're just reserving them because as you start, you want to get the maximum outcome. So starting with haploidentical will be a challenge for us. Maybe this is something Benjamin Mkapa can think of in terms of maximize the care. Another is refresher train. The initial team which was identified, they went to India for a short period of time, and they received the training for almost 3 weeks, and we'll get another training through the Italian collaboration through San Rafael, and we'll have a refresher train for 2 months. Once the team is back, we'll start the first transplant around September this year. We are so much excited because, as you see, our journey is not that long, and we see that we can achieve much. What will make us unique? Number one is cost-effective renovation of the bone marrow transplant. This has helped us to reduce the cost of forming a transplant unit. And we'll start with 2-bedroom, and we plan over the year to be able to transplant around 40 patients per year, and this will go in hand with renovation of the bigger transplant unit as we initially planned. Another is adoption of the protocol from the Indian team, where through our protocol that we are going to use, first we'll use the busulfan, the oral ones, which are very cheap compared to the IV, and we will not include the ATG in the protocol. This will reduce the cost more than 20% to what is being charged by the Benjamin team. So if you're thinking of refer your patient, you can come to us. we can do this in lesser cost compared to what Benjamin is doing now. Another thing, we'll start with less than 6 years of age because they've been shown to have a very good outcome compared when you're dealing with adult patients who are above 6 years of age, given the chronic complication which comes with the long-standing sickle cell disease. But also to reach more patients, we've started also to conduct outreach program, and this will include the catchment area that KCMC as a zonal referral hospital is covering. This includes Kilimanjaro, Tanga, Arusha, Manyara, and Singida. So we've started with the Arusha region, then we'll go to Tanga, Manyara, and other region will follow. Dr. Emanuela, you can invite us. I know you have a lot of patients. So with Arusha region, this outreach has been very successful because we've managed to identify 27 candidates, and we'll plan to have the family and the relative for swabbing, and then probably after we finish our first 5 patients, we'll include the patient from Arusha region as well. But also to smoothening the referral pathway for this patient, we've been in contact with the hematologist and the pediatrician attending this patient so that wherever they have a patient who is a candidate or have met the transplant criteria, for them to easily refer the patient to us. So the journey is not as smooth or like simple, but we have several challenges. Number one is shortage of blood product, despite running a donation unit at KCMC. And this is even worse on our side because we also run a big cohort of cancer patients, and their treatment also demand a very good blood supply. So this makes the blood product to be even more scarcity. But also we don't have a phoretic machine, which also could have easily the availability of blood product. But also donor availability. For some of the patients in our database, they are the only child in the family. So you find they don't have a donor, but they need transplant. I'm happy to hear about the gene therapy program Professor Makani is doing. This can also be a better option for the patient who don't have donor. But also to see an alternative kind of donor, like haploidentical or unrelated match, could be one of the solutions. Another challenge, which is not a bigger challenge on our side, is the opening of the Center of Excellence Laboratory at KCMC. This laboratory is formed by the unit of 3 labs: the main hospital laboratory, the biotech laboratory, which is a research laboratory, and the university laboratory. So they've just harmonized to form a Center of Excellence Laboratory, which will provide all the necessary investigation that are needed in transplant. So this is another big milestone on our side. So in summary, bone marrow transplant in resource-limited setting is feasible and cost-effective in the long term, but also we need to prioritize newborn screening to identify these patients before they develop major complications from the disease. Another strategy is to ensure sustainable and timely blood product supply, which will ease the whole transplant procedure. But also we need funding, as most of the challenge is due to shortage of funds. So we need to get support from the government, partnership, and do even fundraising in order to support and sustain this program. But also we need to promote universal health insurance. I know they don't cover for transplant procedure, but they also help to cover the costs during follow-up visit and reduce the cost to the family. Thank you very much.
Thank you. Thank you very much, Dr. Lillian. And may I now call upon all the speakers of this session to just take the stage so that we can have a discussion. For the interest of time, we are going to hold a 10
Dr.
minutes
Shija, Dr. Stella on the
discussion.
podium.
Please, Professor Ibun, Dr. Shija, Dr. Stella.
Yes, we had our first presenter, Dr.
Dr. Shaw.
Mangoye, Dr. Stella, Dr. Shija, Dr. Shaw.
Let's see those who have hands for questions, hands up. We are running short of time. Hands up if you have some questions. I don't see anyone coming up with a hand. One. Dr. Shaw is not around. Some. Oh, okay. Two. So let's start with Dr. Shakil.
Hello. Congratulations for all the presenters. I'm particularly interested to ask a question to the KCMC presentation. Regarding the protocol that you are suggesting to use using oral busulfan and no ATG. Well, I know you have not yet transplanted, but I presume you have looked into the Indian data on the incidence of rejection and graft versus host disease. Do you already have an idea of what you're expecting? Because as you saw from Dr. Stella's presentation, even with ATG, we still have a significant number of children with graft versus host disease. So I am just interested to learn if you have looked into that protocol. Thanks.
Thank you. Can we take the second one?
Okay, thank you. My name is Julius, medical doctor from the University of Dodoma. So I would have had one question to Professor Ibun from St. Nicholas Hospital. So as we know, the organ transplant process and donation process are two sides of the same coin, meaning that they depend on each other very, very much. So, and as you have stressed enough on the burden of chronic kidney disease, and that meaning that the proper treatment of chronic kidney disease and that decreases mobility and increases the quality of life is kidney transplant. So, and you speak a little bit about disease donation. So, even in countries that have good infrastructure of organ donation, countries like USA, in our regional colleagues like South Africa, they still face shortages on the organ procurement. So as a country that we are trying to embark in this organ donation space, so what would you advise that on the disease donation process so that we can incorporate it together so that when we reach our maximum capacities so that we can decrease the shortage
Thank
of
you.
procured donors. Thank you.
Thank you very much, Dr. Frank Asimwe from Uganda. My question was for the CMO, but she has left. I guess you are in the seat where she was sitting. That's a prophecy. You might take the actual seat she's sitting in. So I'm aware about the cost, 12 to 15,000 USD per transplant. Does the UHI meet the whole cost or a percentage of it? Does this also cover the post-transplant and rejection medication? Is inability to meet the post-transplant and rejection medication an exclusion criteria? Because for us in Uganda it is. If we think you might not be able to afford the post-transplant care medication, then we advise you to put your books in order with God and continue with dialysis. Thank you.
Thank you. Professor Makani.
Asante, thank you. Great talks. So my one question is to, from the kidney transplant in Nigeria, is whether you have a donor registry for, in place for blood stem cell as well as for kidney transplant, because this would really help when you do the HLA typing. So do you have a donor registry? So that's the question. The second is to Dodoma. the question to bone marrow transplant in Dodoma, whether you have any partnerships with industry, because partnerships with industry, both for bone marrow and kidney, really would help to reduce the cost. And then the second question to both of you is whether you're doing any research with the patients that you've already done the transplant. I think this applies to all of the areas, because research is another way that you can supplement the costs. So this is a question, I guess, for all of you. And then the final question is to KCMC. Fantastic roadmap. So my question is, would it be strategic for you to think about doing transplants for other populations? Because the need is very big. BMH have identified matched sibling donors. Perhaps you may want to think about haplo or transplant for maybe aplastic anemia or for cancer. And this way, rather than competing for patients, we all complement and we say, these patients to Tawapeleka, we will send them to Loganzila. These patients, we will send them. So can you comment about, because I was a little bit kind of surprised to say that there'll be competition between KCMC and BMH. So, and then I think the final question is really that comment is there a way, and what would be the best way to have a referral system within Tanzania, but also to Uganda and to Nigeria, or from Uganda and Nigeria? We've had patients from Uganda wanting to come here for transplant. So maybe somebody can speak about that. How do we set that up at Africa level? Thank you.
Maybe we can take the last one from Dr.
Yeah, because we are taught when a professor speaks, no one should speak, but Professor, excuse us for today. The last one.
Yes, so thank you very much to all the speakers. There were very interesting presentations. It's good to hear about the progress. My question goes to Professor from Nigeria. If you can just give a comment about diagnostic services, because that's one of the challenges that is common across all the transplant. When we plan for organ transplant, are we bringing in our colleagues in the diagnostics to make the diagnostics, to monitor treatment, but also to follow up, outcomes from the treatment? Thank you.
Thank you very much for the questions. I think, Professor, you can start with yours.
Not sure you can hear. Can you hear me? Right. I think the first question was as regards disease donor transplants. And really, it should be the ultimate. In the developed world, that is the commonest of transplants that are done. In fact, Spain particularly is well noted for disease donor transplants. And it's the way that we should look to. Because whether you like it or not, no matter how strict you make for us before we accept a potential donor, go through so many hoops. We get them to swear to an affidavit, we send them to external ethics assessors, we get them to make it. But despite that, you still have situations where you innately believe that there is some kind of commercial. Really, what you should be looking towards is developing a disease donor transplant. And it's best for you to start advocating towards it now. Because I don't know what it's like. In Nigeria, even when someone dies, to get them to agree to do a post-mortem is a problem. To now tell that person you want to remove an organ, someone who you still see in the ICU on life support, and you tell him he's brain dead, you want to take out a kidney, and you want to give to somebody, it can be a challenge. It requires you starting advocacy now. Actually preparing the minds of people that this is a possibility, and then while they're alive to actually, advocate to donate. Now, there are two ways of doing it. You have what you call the opt-in and the opt-out. The opt-in is the more commonly available one, which essentially is that whilst you are alive, you are encouraged, and you volunteer and say, look, if I die today, I know I don't need my organs again. Please use them to support somebody else who's alive. And if that happens, it's put on your driving license, and if you die, then you're a potential candidate. But then other countries like Spain are now going out to the opt-out, which means that everyone that dies, unless you, whilst alive, had said, I don't want my organs touched, automatically your organs would be utilized for the purpose of disease donor transplant. And that would be not just your kidneys, your lungs, your heart, your liver. So what you need to do is at the current time, start to talk to the public about it. Get people sensitized to the fact that this is a possibility. So that when you now have the capacity to do it, it is something that would be slightly more acceptable to the general public than it might have been. I think the second question was as regards research. Yes, we actually, aside from the fact that we do things slightly different from what's done in the developed world, we actually do publish our data and reflect on the differences that exist and how that affects eventual outcomes in such patients. I think it's essential that to gain the confidence of the public, you actually get them to realize that your outcomes are just as good as they are with other people and other centers in other parts of the world. Was there another question?
Yes, maybe donor registry also?
Yes, we do have a donor registry, but that is more relevant for disease donor transplants. Most of our donors currently, and we haven't done any disease donor transplants in Nigeria yet, even though we're working towards it. But for live donor, the donor has to be somebody who's the first-degree relative of the recipient.
And maybe the last one was on diagnostics?
Yes, that's the important one. We do now have laboratories in country that can carry out these tests. There are at least 3 or 4 regional centers that we routinely then refer our patients to that can do all the HLA and cross-match. In hospital, we have the capacity to do all the drug levels and all the investigations that are required. It's only the HLA that we send to those regional centers.
Thank you so
Thank
much.
you.
Dr. Lillian, maybe you can also take yours very quickly in 1 minute, especially for, you have 2 questions. If you can respond them in 1 minute, please.
Okay, thank you. To start with question from Dr. Shakil regarding the protocol that we are going to use. Yes, we have not yet started the transplant, but through our partner, which we went also to India and see the protocol that they're using, it has a very good outcome. And from that center, we saw they have more than 10 years experience in terms of transplant, and they've done more than thousands of transplants, and they're using the same protocol. But what is significant, what we noticed, before the patient is admitted for transplant, they make sure that the patient is on a constant dose of hydroxyurea, which this is most of the time the challenge for patients. Sometimes we may find the patient is not on a constant dose of hydroxyurea, which can also have an impact in terms of outcome of the transplant. So the ATG is only used when they have maybe ABO mismatch or haplo in terms of reducing the risk of GVHD. But from what we see and the partner that we are working with, they've also done using the same protocol in different other centers in Africa, which they also have a very good outcome with that simple protocol. Yeah.
There was another question on if you can consider other population.
Yeah, so thank you very much, Professor, for your question. Sorry that if it came out as a competition, but this was just selling idea to the Benjamin team, whether they can also consider adapting that protocol, because it significantly reduced the cost. And so our vision as KSMC is to start the bone marrow transplant, not only for sickle cell patients. As you can see, much of the team are coming from the oncology center, where we're dealing with other patients with acute leukemia, multiple myeloma, and even aplastic anemia. So our vision is not only to end up with sickle cell patients, but we are focusing on starting transplant to patients with acute leukemia and other disease. But when it comes to gain confidence from the team, you need to select the best disease, the simple one with a very good outcome, and sickle cell was one of them. And then later, once the team has gained confidence, we'll consider other conditions. And we have a very good collaboration with the Benjamin team, and maybe in the future we can see if Benjamin Mkapa can be the Center of Excellence for sickle cell transplant, and we can remain doing acute leukemias, aplastic anemia. That is the future. Yeah.
Thank you. I think there was a question on referral systems. It could be taken by anyone.
She just pointed out that we might have missed that out. Well, incidentally, there is an African Association of Nephrology, and AFRAN has a subcommittee on renal transplantation. And one of the things that committee has done is to collate data as to the availability of transplant facilities in different parts of our continent. Clearly, I mean, some centers are ahead. South Africa and quite a lot of Maghreb in the northern part of our continent. There are centers also in Kenya and Nigeria. So there are centers where rather than send samples abroad, you could consider sending your samples to centers within Africa, hopefully at a reduced cost, to make sure that we can expand services. And this also now tells us of the availability of those resources in different parts of our continent. So there needs to be a lot more of South-South collaboration. We shouldn't just rely on sending people abroad, which increases costs. And so, easily, once you now know that, whilst I was speaking with the team yesterday, now that I realize that there's a capacity to do bone marrow transplants here in Dodoma, I'm already speaking to somebody back home in Nigeria and say, look, if you need training, rather than go to Switzerland or why don't you consider coming to Tanzania? That is the sort of collaboration that easily we should try and encourage. And that way we can very rapidly, enhance our numbers. Thank you.
Thank you. I think there was one question on partnership with industry. I think anyone can respond to that. Stella, do you want to take it?
Yes, thank you. So looking at the cost drivers of transplant services, but specifically for bone marrow transplant, we realized that, for example, ATG medication costs almost 25 to 30% of the total transplant cost. So we have made a number of communication with different partners to see how best we can reduce the ATG cost. So most of these collaborators that we are reaching are suggesting that probably we go straight to the manufacturers and probably see how best we can reduce the cost of supply of medication from where they are manufactured to where we are getting. So another area is also blood transfusion supplies. So again, we are in communication with different suppliers who manufacture these kits for exchange transfusion. So we think, yes, there is a significant cost reduction once we partner with industries that directly produce these items that are used in transplant services.
Thank you. There was the last one was directed to CMO. I think anyone can respond, even from the audience. It's about insurance. Shija, you want to start with that?
Yeah, I want to start with that. Regarding the NHF coverage for kidney transplant, at the moment there is no defined transplant cost for transplantations. However, NHF covers service by service, and most of the services which are covered includes immunosuppressions, wake up, admissions. There are the remains one is some laboratory tests which are, of course, are not defined in their packages. So almost 80 to 85% coverage of the services which are related with kidney transplant are covered in the NHF to beneficiaries of National Health Insurance Fund. You also wanted to know whether some of the individuals are not covered with NHF if they are also provided with services. Our government provides funds for unprivileged group every year, so we also transplant. We are not selecting, or we are not leaving behind someone who do not have national insurance fund. Thank you.
The last, yeah, you can take the exclusion criteria.
Yes, I think the exclusion criteria with the case of immunosuppression, especially post-transplant, is a major criteria. If you cannot afford transplant medication after surgery, it means maybe you should wait. It's not very good to take a donor's kidney and then fail it because you could not afford. There are the schemes that are available for NHIF to support immunosuppression, but maybe not very accessible yet because the cost is still very high, and the government is assisting. However, much more effort is required to make sure that they are available at an affordable cost for most of our patients.
Thank you very much. Colleagues, join me in thanking our presenters. You'll agree with me that they've done a great job in taking us through the organ transplant, where we are and where we want to go, including the challenges and what are the potential solutions. On behalf of my colleague, Alfred, we say thank you for trusting us to lead this session.
Thank you, Dr. Faraja. It's sure we still have questions. Yes or no? Many people still have questions. So, welcome to the third UDOM Scientific Conference on Health from 10th to 12th June in Dodoma City Hall, where we shall have a plenary as well as breakout session on transplantation therapy. So we shall be having another discussion on the same, because you know there's many issues that still need to be responded to. Asante sana, mwenyekiti.
Asante sana, moderators, Dr. Faraja and Dr. Miremo. We are very delighted by your leadership in leading these particular presentations. I want to make some few announcements, which are housekeeping, so that when we are going for the second session or another session, we are all abreast with important informations. For those who want to use the washrooms, they are available on our left side of the hall, and some are available on the other building. We will run another session before we go for lunch, and we will be led by Dr. Abdallah Baja. Dr. Abdallah Baja is a director of clinical support services at our hospital. He is a renowned microbiologist working with Benjamin Mkapa Hospital. He is the one who will be leading the next session. And after that, we'll break. After almost the 3 presentations, we'll break, and we will be taking our lunch. And after our lunch, we'll be having 1 or 2 presentations. Then we'll have an open dialogue discussions for many things, including the roadmap. Lastly but not least, I would like you to take note of the handbags that have been distributed across everyone. That you'll use it for the rest of your life. We give it to you for free. Thank you very much for receiving it. That's number 1. Number 2, inside it, there is leaflets about the hospital and the book about the hospital. But also there is an important card. There is a pledge card. If you're interested to look at it now, I'll be very happy so that I can explain. There is a pledge card. Towards sustainable financing of transplant services at Benjamin Mkapa, we are doing a fundraising activity to support those who are in need, the like of others who were presented here in the morning. And in that pledge card, we want you to pledge whatever amount you can donate, you can support. Tanzania is rising, not
only in symposium, but in financing its own healthcare, including there is a pledge card, not a leaflet, there is a pledge card. If it is not in your pocket, then we'll be giving you, oh, it is missing too many. So we'll distribute some pledge cards. They are blue like that one. Please pledge anything and we'll be in contact. The fundraising will be finalized on 15th of July by Her Excellency, Madam President, who will be officiating our gala dinner to finalize that. Dr. Baja, the floor is yours, and the first presenter is Professor Rugajo. You will introduce and continue. Thank you very much for your attention. Santeni sana.
Asante sana, Dr. Mugisha. As I've been introduced, my name is Dr. Baja.
Sorry, before you continue, can you stand up and stretch on the left, on the right, so that we avoid DVT, we avoid hemorrhoids, we avoid many things. Stretch and then sit. Okay. You may be seated. Dr. Clara Chamba. Dr. Clara Chamba, kindly join Dr. Baja on the moderation of this session to cover for Mr. Yonaz, Dr. Yonaz, who is not with us for many other good reasons. Thank you very much. The floor is yours.
Okay, thanks, Dr. Mugisha. Yeah, well, as being introduced, my name is Dr. Baja. Professionally, I'm microbiologist and immunologist. I will be the moderator of this session. I'm going to start with a topic with the name of the transplant workforce and infrastructure. This will be a video presentation, and actually it is coming from Professor Pasco Rugajo. Who is Professor Rugajo? Professor Rugajo is a consultant nephrologist. He has 76 publications, and actually he is a former director of curative services and a dean of Muhimbili University of Allied Sciences. He did not manage to be with us today, but he said no, he must have a presentation. And therefore, we are going to see and listen a presentation from him. As I've said, it is regarding to the kidney transplantation, health workforce, and the infrastructure. You can play the video now. Thanks.
Good morning, colleagues. Thank you so much for that kind introduction. I am very delighted to take part in the first transplant symposium. That is very symbolic and that is very timely. I like the theme, Roadmap of Organ Transplant in Tanzania, and the organizers assigned me to present on kidney transplantation, health workforce, and infrastructure setup. Of all my credentials today, I just like to underscore that the African Association of Nephrology Conference 2027 is going to take place in Tanzania, Dar es Salaam City, and that will be in June 2027. You are all invited, and I'm going to share a few more details towards the end of this slide. I declare my affiliations to Aga Khan University, where I serve as the Dean, to Aga Khan Health Services, where I serve as a consultant nephrologist, to Nephrology Society of Tanzania, where I'm honored to be the president, and to AFRAN, where I'm serve as the local organizing committee chair of the upcoming conference. First and foremost, heartfelt congratulations to Benjamin Mkapa Hospital and UDOM, the administrators and staff, for coming together and put this first kidney transplantation symposium. Again, congratulations to Bugando Medical Center for achieving a very admirable milestone of conducting the first kidney transplantation in Kwanza. This now is our third in-country transplantation program. And peculiarly, this was done using a local-to-local collaboration with Benjamin Mkapa and Bugando Medical Center coming together. In a way, this also makes Tanzania a very unique country in the sub-Saharan Africa to have not one, not two, but 3 in-country viable transplantation programs, which is a feat by its own. Of course, this could not happen without the government will, without institutional leadership and support, without transplant teams themselves to be very zealous and very determined, but also we owe our patients a lot of thanks because of their trust in our local kidney transplantation programs. 2 weeks ago, I was lucky to be led by Dr. Rudovic and Dr. Kanenda to say hi to the patient Heavenlight, who was just post-op at Bugando, and you could see the joy in him and his wife that this is now possible in Tanzania, and they were just hoping that more and more patients will benefit from these programs. So, as I said, back in 2017, Muhimbili National Hospital took the first challenge in collaboration with BLK Max Hospital in India. They were able to do the first kidney transplantation. Today, they have saved more than 130 recipients. A year after, in 2018, Benjamin Mkapa and UDOM, in collaboration with Tokoshkai Medical Group or Medical Corporation from Japan, were able again to do a successful kidney transplantation in Dodoma. In between then and now, there have been so much transfer into local practice. Today, we are very proud that the entire donor recipient evaluation, operations, and post-operative care is taken by our local experts. That couldn't be evidenced more by the latest feat when Bugando Medical Center, combining with Benjamin Mkapa, were able to do a successful kidney transplantation without any external aid. So this again is a marker of how far we have come and how confident we can go forward. From the classical teaching, we are taught that progressive kidney disease should be prevented first by everything, knowing individual risk factors, familial risk factors, but also community interventions that also include advocacy and early screening and early referrals. But nevertheless, the progression is inevitable, and it will progress from CKD stage 1 to CKD stage 5, which will call for renal replacement therapy. In between, patients could be led to have a number of management choices that also include conservative kidney management that just rests on optimizing care for the underlying native kidney disease, whether it is the hypertensive nephrosclerosis or diabetic nephropathy, just optimizing it. And it could as well be the treatment of choice for patients who do not wish or are not medically indicated to go for dialysis and kidney transplantation. But as you know, majority of our patients go from conservative management to dialysis, for which in our country, by and large, it is hemodialysis. But in other countries, continuous ambulatory peritoneal dialysis is also an option. But then after that, patients progress, especially those who are medically indicated and can have the access for kidney transplantation, because kidney transplantation so far is the ultimate management modality that ensures longevity, quality of life, and return to work and other forms of lifestyles. While we appreciate that efforts are still undergoing to try and discover an artificial kidney, but this is still very experimental, and it stems from the fact that a kidney is a very complicated organ with more than 8 independent functions, and some of these are fine-tuned to be even behaving in circadian rhythm. So trying to be very innovative and try to fine-tune all these functionalities into a machine has still remained elusive so far. But every time we go to international conferences, we are given updates, and hopefully one day we will wake up to get informed that an artificial kidney has been discovered. Hopefully that will also usher us into a new era of probably not doing kidney transplantation, or not doing dialysis, or not prolonging the conservative management and jump straight into the artificial kidney. So since its inception, kidney transplantation practice has been shrouded with a number of ethical and legal dilemmas, malpractices, desperation, and business interests, so to speak. So countries saw the need to have this regulated and coordinated. So they assembled in Istanbul, Turkey, and they vowed and committed to uphold the Declaration of Istanbul that promotes legal and ethical kidney transplantation practices, but also denounces organ trafficking and transplant tourism practices. Equally important are the KDIGO clinical practice guideline for care of kidney transplantation recipients, but also national or local legal frameworks are important, just as also institutional SOPs and guidelines. So it suffices to say that Tanzania is now transitioning from the SOPs and guidelines. A team was, or a committee was working on this for several years, and I'm informed that a bill is about to be tabled in the parliament to be debated, and upon agreement, it will be sent to the president for signing into a law. So we hope that in the near future, we will have a solid organ harvesting and transplantation law in this country that will also allow us to expand into other forms of kidney transplantation practices. So eventually, it is about a medically fit, voluntarily altruistic donor who is medically, surgically, and psychologically cleared to transfer or to donate the kidney to a medically indicated recipient who also has gone into a lot of tests to see if the kidney he's going to receive will be compatible and will be tolerated in his body. So there is so much investment that goes into donor and recipient evaluation. For example, we must make sure that the donor and recipients are blood relatives, because as of now, in our country, we do the so-called live-related donor kidney transplantation. Other modalities of kidney transplantation probably are beyond the scope of this talk, but we can briefly mention as we go by. So a lot goes into proving that the donor and recipients are blood relatives as close as possible, and they should also be ABO compatible, HLA compatible, at least by haplomatch or beyond. But also we have to make sure that donor-specific antigens and panel-reactive antibodies are at the minimum to ensure that the graft will be taken by the recipient and reduce the chance of especially hyperacute or even delayed graft rejection. So long before you contemplate on the kidney transplantation, as I said, many departments should be ready to support the program. So the hemodialysis program in a specific hospital that is embarking on a kidney transplantation has to be a mature program that is capable of running conventional dialysis and other advanced form of dialysis like CRRT and plasmapheresis when needed. But as science progresses, we are also moving towards accepting less histocompatibility organs. But this to happen, there is an investment in a phase called induction, in which case a recipient is exposed to a certain type of medications to lower the immunity, but also plasmapheresis when needed to remove some antibodies, especially the panel reactive antibodies, to put them very minimum so that the graft can take. So in the peri-operative complications, we need also to invest a lot of surgical interventions, but also early detections of infections early detections of hyperacute graft rejection, and how to address them. Similarly, post-op and during early post-op phase, there is a heavy immunosuppression that renders patients very prone to getting infections, especially viruses, fungal, and some bacteria. And some of these infections, especially viral, are very specific to transplantation patients. So you must have heard of prions or BK viruses, and probably these are not common for other types of patients. So much investments in terms of detection, the diagnostics, and the interventions for both early infections, hyperacute rejections, surgical complications, as we also plan for long-term evaluation that is also heavily protocolized, and that also demands a lot of investment. Equally important is the therapeutic drug level monitoring. Maybe you have heard about TAC levels, and because when the patients are put under immunosuppression, you want it to be in the therapeutic window, not too much to be toxic, not too low to allow rejection. So this again involves investing in machines like HPLC and those other machines for detecting area under the curve and peaks and trough levels of medications to ensure there is no rejection or toxicity. At the same time, there is a whole host of anti-rejection medications and anti-rejection interventions that are also part of the pharmaceutical investment, as well as, again, the surgical competence for graft nephrectomy, removing the graft from the patient if needed, and if all goes wrong in terms of what was expected, then the patient graft is retaken and the patient is committed back to dialysis. So similarly, donor evaluation is a heavy investment because usually donors are young people, very altruistic, very loving, who have voluntarily decided to offer an organ to their loved one. So they have to be protected. They don't have to be sacrificed. They don't have to be compromised. So a lot goes into proving that they will survive with one kidney, which should not be a problem, for the rest of assumed lifetime. And they are not having the traditional risk factors that can turn the remaining kidney into progressive CKD, as well as they'll be able to return to their work life and quality of life without being compromised. So once the psychological, the medical, the motive, and the surgical conditions are approved, and the legal and ethical clearance is also obtained, usually a living blood HLA-related voluntary altruistic donor will progress to donate a kidney. As I said, the donation could be the conventional nephrectomy, or it can as well be nowadays a laparoscopic nephrectomy, or it can as well be a robotic nephrectomy. All these are also meant to reduce the recovery time, but also reduce the scar after donating a kidney. So once all these considerations are made, a donor is taken through literally 3 stages. The first stage would be just to ensure that these are relatives, as I said, to avoid a lot of legal tangles, but also to avoid incompatibility. So HLA blood group compatibility is very important, but also we want to rule out any history of cancer, diabetes, and significant heart, lung, liver disease, as well as kidney disease itself, as well as BMI more than 35, because obesity is also an independent risk factor for progressive kidney disease, especially related to FSGS. Then the second stage would be including all the blood workup to see also the kidney function, if it is not compromised before we donate, but as well as picking if there are any markers of progressive kidney disease from the urine. These patients will also be subjected to nuclear medicine imaging that can include the DTPA to check for the split kidney function, to allow during surgery to choose, and even before surgery, to choose which kidney the patient or the donor is going to donate, because we want to leave the donor with the better functioning kidney. But also another type of nuclear medicine would be DMSA, which is just meant to look at the textural integrity of the kidney, look if there are past scars from previous infections and so forth, as well as the 99 technetium Mag3, which is also meant to look for, again, integrity and split function. But also conventional radiology like chest x-rays, abdominal ultrasound, Doppler ultrasounds to check for blood flows, to check for resistive index. That also help to choose, to look at the donor kidney before it is procured, to look at the vessels, the malformations, and choose which kind of surgical approach would be optimum. But also we all know that they need to be fit, so echo ECGs for the heart is important, and above all the psychology, that there is no stress, there is altruism, it is purely voluntary, and there are no incentive benefits that the donor have been promised, because that will be against the Declaration of Istanbul. So once the donor passes this, the final stage would be again to do the measured GFR. The first one was the estimated GFR, but this will be the measured GFR, which is as actual as possible. But also we would like to do a pre-anesthetic checkup to see if there are no contraindications to anesthesia, and prospected that the surgery will go on well. So fast forward, during the operation itself, so much investment also goes into that. It needs a double theater, because these operations take place in tandem. You have the donor nephrectomy in one room, and the recipient team is also waiting for the kidney to be procured. So there are some modifications that are needed, sometimes building a twin theater or putting these two theaters as close as possible, because you also want to reduce the so-called warm ischemia time and cold ischemia time, because all these are important, especially the cold ischemia time is meant to make sure that the organ is functioning by the time it is transplanted to the recipient. The table is also a breakable type, so that the donor is positioned with the kidney maximally exposed. The surgeons know this better. But again, additional investment will depend on whether the approach is conventional, laparoscopic, or robotic. There is a picking table that contains ice balls, cold perfusion liquids like the University of Wisconsin fluid. These are meant to perfuse, but also to suck for all clots when the kidney is in transit between after the nephrectomy, but before implanted to the patient. We have to make sure that the kidney is preserved as maximally as possible, because this is, as you can imagine, a lot of investment so far to take the kidney and to implant it in the patient. So after that, we make sure that the surgical procedures goes as expected. Usually anastomosis should be really intact without leaks, but also the implantation of the ureter to the kidney or to the urinary bladder of the recipient should be perfect, with a certain specific technique to make sure that there is no urocell, which is a urine leak post transfusion. Ideally, if the operation goes well, there will be copious amount of urine that is produced immediately when the kidney is grafted. Actually, sometimes in more than 10 double-digit liters within the next 24 hours. And this is always a joy to both the transplant team, but as well as the patient, who, having been on dialysis for quite some years, might have even lost the capability to produce urine. So equally important is the transition from the operation theater to the ICU, the recovery, ICU, HDU, isolation. All these are heavily invested treatment areas with, in some places, negative laminar flows. and to ensure that all IPC protocols are highly observed. Asepsis is the order of the day because a slight contamination could really jeopardize the entire exercise. So again, with it goes with close monitoring of vitals, urine output, and the, as I said, postoperative issues like urocell and leaks. Post-operation, we expect the donor to recover very swiftly. Actually, the donors should not die out of the altruistic process of donating a kidney. They say a chance of a donor dying from a sunstroke is about 1 by 4,000. But a donor dying out of donating the kidney is about 1 by 11,000. So you can imagine the odds. It means a donor is easy to die with sunstroke than by the altruistic process of donating the kidney. This again is a responsibility for the entire team to make sure that the procedure is very safe and secure. After that, donors usually recover very fast within 1 week. Now for laparoscopic and robotic surgery is probably even lesser than that. And they are supposed to go back to work probably within 2 or 3 weeks after that. And their follow-up is important, is protocolized, but it's not as strict and stringent like that of the recipient, who might have to stay in the theater and into recovery, and as well as into the HDUs and isolation for quite some time. And again, even after discharge, which usually again takes place allowed within the hospital proximity in the nearby quarters, probably for 1 month very frequently, and then between 1 month and 3 months very frequently before allowed to maybe travel elsewhere. And then after that, there is a midterm follow-up that is between 3 months and 1 year, which is also frequent, probably monthly or 2 monthly, depending on the protocol. But beyond 1 year, we still also want to see either quarterly or half annually for quite some time, up until when we are confident that we can see them either annually or whenever needed. So equally important is, again, as I said earlier, is about immunotherapeutic toxicity and compliance. And speaking of compliance, compliance is such a strong factor that has to be determined even before the operation. If the recipient or the prospective recipient was not compliant to normal medications like antihypertensive or oral hypoglycemic drugs, or was not compliant to dialysis therapy, this patient will also not be compliant to immunosuppressants that are heavy, that are more toxic, so to speak. So if non-compliance is proved before the operation, it is a strong contraindication for the operation itself. And probably the patient should remain with dialysis or with conservative management, rather than investing so much for transplantation and then kill the kidney just by not being compliant. So surveillance of infections is a continuous role. Giving patients or recipient the necessary vaccines is also very important. Surveillance for chronic allograft rejection. Some centers even do 2 years, 2 years post-operation or post-transplant, they do something called protocol biopsy, just to see if there are any signs of chronic allograft rejection and address them early. So these are constant surveillances. But sometimes the graft fails and patients have to return to hemodialysis. And sometimes patients, unfortunately, may die with a functioning graft, which is such a bad feeling. Okay, so in a nutshell, those are important components of the infrastructure that we need to set up in place for a kidney transplantation. I'm not saying it is exhaustive, and probably I've skipped so many specific details, but that is a bigger picture. So for the workforce personnel for a successful transplant program, you need the so-called MDT, the multidisciplinary team. This involves more than 12, 13, even 15 well-functioning departments that are highly coordinated. Those are surgical, medical, anesthesiological, pharmacists, social workers, transplant coordinators, dietitians, you name it. So these have to be broadly specific, highly coordinated, functioning together, and replenished, developed, given opportunity to update their skills, because the science of transplantation evolves every day. And as you go into other modalities of transplantation, say cadaveric transplantations and others, you need even better and more skills. So it should be just appreciated that it is a multidisciplinary team, and it has to be well coordinated to function optimally. So worldwide, still there is a shortage of workforce for kidney healthcare. I would take just nephrologists as a proxy for these different cadres around the multidisciplinary team. So if you look at the heat map on the left, so the average number of nephrologists in the world per 1 million population is 11.1. That is to say, there are 11.1 nephrologists for every 1 million population. But this is a global figure. If you look at the map, the darkish bluish and the light bluish regions of the world, those are either on average or above average. The remaining colors, those are not reaching the optimum average. And it represents countries like ours, the sub-Saharan Africa, and actually in particular, even in our country, as you'll see in the next slide, we are falling into the East Africa region. There is only 0.2 nephrologists per every million population. That is to say 2 nephrologists per every 10 million population, as well as 0.08 nephrology trainees per as a million population. So not only the existing force is shrinking or is still suboptimal, but even the training is still suboptimal. So we need to work both to retain, motivate, develop the existing workforce, as well as do a lot of investment on pre-service training of nephrologists in this case, but all other cadres, as I showed in the previous diagram, when it comes to the multidisciplinary team. So I'm sharing with you Global Kidney Atlas, also the African Journal of Nephrology Roadmap for Kidney Care in Africa. But as well, I would like you to refer to the local research on developing nephrology service in low-income countries, a case of Tanzania, by Furia et al., and the local Benjamin Mkapa publication on kidney transplantation in low-resource countries, 6 years of successful and challenges, of successes and challenges at Benjamin Mkapa Hospital in Tanzania by Shija et al. These are meant to tell you the journey, the requirements, and the challenges when it comes to workforce. So still there is work ahead. We still overemphasize on prevention and deceleration of progressive CKD as a true public health approach that is value for money, because we have to appreciate that fancy as it sounds, successful as it is, still kidney transplantation access, especially in our world, is still limited. So more should go into public health prevention, public awareness. And we should also be aware that increasingly there is shrinking donor pool. There is less and less people who are loving enough to donate their kidneys. So we ought now to start considering other modalities and maneuvers for expanding the donor pool. So there is expanded criteria donors. Probably these are hypertensive donors or marginal age donors. Sometimes in developed countries, they even go for either brain or non-heart beating donors, just to expand the donor pool. But at the same time, when we have learnt enough, when we have invested enough, and when we have regulated enough, we can dare to venture into the cadaveric kidney donations. So I also urge this symposium to come with one resolution. Now it is about time to start the Tanzania Transplant Registry, because this will help us develop cohorts From those cohorts, we can develop research, we can attract grants, but we can also conduct clinical trials that are both scientifically informative, but they're also going to inform the policy for better decision making and planning. We need to embrace the ethical and legal framework. The Tanzania Solid Organ Harvesting and Transplant Law, I think it's about time, and I'm happy that in our midst we have representatives from the Ministry of Health. So maybe the DCS will help us to follow up where is the process of the bill and when is it going to be debated and what's the time frame for it to be a law. Because as we embrace more and more practices, we need to be more and more regulated and more legalized. So, we continue emphasizing that the Istanbul Declaration is an overarching guideline, much as the KDIGO guidelines also are, and the SOPs and guidelines for the institutions. So whenever we embark on these transplantation procedures, we should always make sure that we legally.
Thank you, Professor Rugajo, for that insightful presentation. A round of applause for Professor Rugajo. He has walked us through the procedures of renal transplant, but clearly highlighting the capacity that we need to go through these procedures, and clearly we can see we still have a lot of work to do in building capacity. My name is Dr. Clara Chamba. I'm a hematologist and head of department at Muhimbili University of Health and Allied Sciences, and I'll be the co-chair of this session. And so up next is Dr. Edith Shosemlai. Yeah, and she is coming to us from the National Health Insurance Fund. She's based at the headquarters here in Dodoma, and she's working on the processing. She's working with processing and management. And she's also a key stakeholder when it comes to transplant, but she is now, we're going to be moving now and looking at the finance side of things. So I welcome you, Dr. Shoze. Karibu.
Respective other stakeholders for NHIF and respected distinguished guests, a very good afternoon. It's my pleasure having this opportunity to speak to you this afternoon, and on behalf of the National Health Insurance Fund and the Director General for NHIF, I recognize and appreciate the quality of services you are providing to NHIF beneficiaries. And we also recognize the transformation the Benjamin Mkapa Hospital made for the organ transplant. We really like to congratulate you. And now let me tell you about NHIF. What are we gonna do to support the organ transplant? Kama vile naona mvua ya maswali na itanijia. Okay, so let me introduce to you how NHIF gets started. So the National Health Insurance Fund is a statutory social health insurance scheme established under the Act, cap number 395, and it was started operating in July 2001. Initially, we covered all civil servants, and subsequently, we made amendments to the NHIF Act, and we extend NHIF memberships to cover all the public sector employees and other groups of members in the society. But currently, under the Act number 13 of 2023 of Universal Health Insurance, the Universal Health Insurance was established to ensure that every resident has access to health insurance coverage. So what the problem statement under the organ transplant? We have a rising burden of kidney failure and sickle cell disease. And also we have a long-term treatment cost. As we can see, these patients undergoing dialysis for a long period of time, and we have a limited transplant access in the country. So under the UHI strategic context, the shift toward universal health insurance and the need to include high-cost life-saving procedures in the fund, and we focus on the sustainability and the accessibility and equity in the medical service provision. So the renal and bone marrow transplant overview has been said. Many of us talked about it already. And the cost, here we have a literature review. Estimated cost for the renal transplant is about 39 million to 65 million. But this one, as an insurer and actual evaluations, because it's paid once, so the cost might be lower as compared to the patients who underwent hemodialysis in a long-term duration. And here are the estimation for the person who undergoing dialysis annually. It's up to 26 million or to up to 39 million per year. Similar to the bone marrow transplant, as we reviewed the literature, we saw that the bone marrow transplant cost is about 52 to 100 million. So this includes all the diagnosis steps and procedures, and even hospitalization. Let me go quick to the role of NHIF on transplant. What will we support in these procedures? So it had been asked before that what are we going to cover? Recently, NHIF can cover pre-transplant services like specialist consultation for nephrologists, hematology, and the whole team will be covered. Diagnostic investigation like imaging, lab tests, but there are some of the investigations like HLA, those are not yet under the package. So pre-transplant medication, there are some available in the package, and this depends on the scheme the patient having. And then we cover another cost we cover is for dialysis service and hospital admissions. If the patient is admitted to ICU and in the normal wards, we cover. NHIF coverage post-transplant services for follow-up, visit and clinics. We also cover for some of the investigation after renal transplant and infection screening, or for the patient who undergo rejection, we also do some of the investigations. So lifelong immunosuppressive medication like tacrolimus and cyclosporine, these are under the package. Management of complication, infections, these are all covered, and readmission and supportive care after the procedure are also covered. So what are our expectations under the UHI? Because to support or cover these organ transplant, we need to have many residents who are applying for the insurance. So if we, under UHI, if we have many customers, then we will have enough fund to cover these procedures. And then we will, our expectation is to add some more cost for the investigations, but it's depend on actual evaluation and UHI achievements. So, way forward for the NHIF, we have to strengthen and screen programs, to conduct screening programs. This is also available for corporate customers, but by now, as I am speaking, we will conduct several health screening for every of our beneficiaries. It will be conducted annually, or it's depend on how the nephrologist or the specialist will going to recommend to prevent this disease. So we will promote health lifestyle by conducting bonanza, or we will conduct also primary health care service provision before these patients get into end-stage renal disease. So way forward and the strategic action, as I said, is to support the fundraising in collaboration with Benjamin Mkapa and other stakeholders, and to provide supportive medication, investigation, and hospital admission after the procedures. So, in conclusion, transplant reduces the long-term healthcare costs, and it improves survival and quality of life for these patients. And preventive care is critical for sustainability and screening, for sustainability of the fund. NHIF is also essential to achieve a universal health insurance coverage. Thank you for listening.
Thanks, Dr. Editha. Dr. Editha has taken us through some key important points regarding rising burden of the kidney transplant, but also he mentioned about the estimated renal transplant cost. He explained about the hemodialysis visits transplant, but also he mentioned some bone marrow transplant cost, and actually he analyzed it in details, but also he gave us the way forward as NHIF they are thinking. Okay, now we go to the third presenter of this session, and this is Dr. Lelo Baliyima. She will take us through transfusion and transplantation. While he's blood safety in Tanzania, and also he's a member of International Society for Blood Transfusion. Dr. Lelo, welcome.
Thank you.
Sorry for saying she.
No problem. Good afternoon. I've given this opportunity to talk on how blood donation system supports transplantation services. And I'll be a bit brief on Tanzanian perspective, so as we can have common understanding on what does blood transfusion service offer that can be used by transplantation programs. Starting with blood transfusion service, we play a critical role on organ and tissue transplantation, and we are tightly connected as we all share patient services and ensure that the transplantation goes very well. On our services, we mainly ensure blood availability during transplant surgery. We also support blood group and compatibility, cross-matching, and we also support management of patients before and after surgery. We also do the screening of infections, and we stabilize hospital systems by ensuring availability of safe blood wherever needed. And I believe if we don't have enough blood in hospitals, we cannot perform transplant, as we'll use it for emergency services. So if we look on this presentation, if we look on organ transplant and the blood donation system, we all have a common foundation. We are founded through altruism, we are founded through safety and ethics, and we all do screening and testing of blood and organs to be transplanted. We also have quality standards, and we need trained workforce to ensure transplant and transfusion goes well, but also we all need infrastructure to make things work well. So the blood transfusion service works with the voluntary blood donors to ensure we collect, we screen, and we distribute blood to the hospitals for needs, including transplant issues. But also the transplant programs ensure availability of organs and tissue. We do donor evaluation and matching. They do transplant surgery, and they do post-transplant care. So we meet at the middle on altruism, safety, screening, quality standards, and trained workforce to ensure transplant goes well. If you look at activities, services, if you look at liver transplant, needs packed red cells, fresh frozen plasma, and the platelets in different amounts, and is the most requiring blood transplant. And we have been talking of kidney. It mildly require a lot of blood, but we also have other transplants like lung, heart, and pancreas that needs a number of blood units. We as National Blood Transfusion Service, we are organized at all levels. We are available at all levels with around 250 blood collection centers. We have 8 zonal centers, and we do blood collection in all specialized hospitals. But we also have 26 regional referral hospitals that are collecting blood, and we have 186 council teams that does blood collection. Our first role is to create public awareness on voluntary blood donation. We usually encourage people to donate blood from voluntary blood donor, though there is few number of them are collecting from family replacement. And we do collection, screening, typing, grouping, and storage of blood and blood products. We do production of blood components, and we do maintain the blood donor database. Since we started the program, we have a database of all blood donors, those donated once or regular blood donors. We provide technical guidance to health facilities on utilization of blood and blood. We do blood donor mobilization for the community and the voluntary blood donor, and we do blood collection in our 229 blood collection teams. Last financial year, we were able to collect around 648,000 blood units, and we have a donor registry with 3.6 million donors, among them 253,000 donors are regular. We produce blood components, we produce red cell concentrates, we also produce the leukoreduced packed red cells. This service has started in the past 2 months. We produce the fresh frozen plasma, we produce the platelets, and we also produce the cryoprecipitate. We do blood groups, blood screening using the chemiluminescence assay for HIV, HBV, HCV, and syphilis. But we also do blood grouping for ABOD, RISAs, antibodies, and titer. Counseling and services we also offer to blood donors, those who are found to be positive for infections, and we link them to care and treatment. We also support trainings and research, and we are open for collaboration. We have a number of challenges. Our community is not aware on, awareness of the community on blood donation and organ donation is still very low, so we have to put some more efforts on how to sensitize the community on blood donation and organ donation. But we are operating without an act that governs blood donation or organ and tissue donation. I'm not sure with the hospitals what law are they using. Probably it's a goodwill, or I don't know, but we will discuss, I think, later. We have a blood donor registry system, but our challenge is to maintain it. It's costful because we bought it from Spain, and it's a bit expensive on maintaining it. We have challenging on funding for blood safety activities that makes it difficult to adopt some new technologies because of availability of resources. Our future plans, we are thinking of starting to do HLA typing at the NBTS zones. As we have seen, we have about 4 transplant hospitals, but every hospital does HLA typing to others does it in Germany, others does it in Muhimbili, others does it in KCMC. But if we centralize this service, I think we can reduce the cost and get more out of it. We think of developing a blood donor and a HLA donor registry. We are planning to start stem cell collection. We will be starting with the Mbeya Zonal Referral Hospital, and with the collection of stem cells, we will also be doing transfusion, red cell exchange, and plasma exchange services. We feel like if we get support, we can develop a blood and tissue or organ donation transplant act. We are planning to have a cost recovery for blood services, and currently blood is given for free. And we think we are planning to increase the quality of blood products at a reduced cost. This challenge is more on blood platelets. Currently, if you use the apheresis platelet, the cost of 1 kit for apheresis donation is around 300 USD. So we are adopting some other system, the Revel system from Terumo, which will be reducing the cost to around 100 USD per unit of platelets. Thank you very much for listening. And
thank you, Dr. Lelo, for showing us where we stand when it comes to transfusion services. And we cannot overemphasize the need for a strong transfusion service when it comes to transplant medicine. So our next speaker is going to be Dr. Siana Nkia. She is a senior lecturer in the Department of Biochemistry and Molecular Biology at the Muhimbili University of Health and Allied Sciences. She is a biomedical scientist with over 15 years of research experience in molecular biology and human genetics, with a strong focus on sickle cell disease, malaria, and pharmacogenomics. And she is going to be taking us through the role of genetics in organ transplant. I continue to ask you to reserve your questions. We will have a Q&A session at the end of these presentations. Dr. Siana, you're welcome.
Thank you very much, Chair. A very good afternoon to all of us. I should really start by commending the organizers for this historical event for our country as well as Africa. Hongera sana, and thank you so much for inviting me to be part of this important event. So I'm going to be taking us through genetics as applied to transplant. And I think, as we all know, the basic biology, genes are the basic information that we carry which determine the kind of proteins that we synthesize. So these can be antigens, different cell receptors, antibodies, different transcription factors, and the like. And so when we talk about transplant, it's really important for us to also put into context how genetics basically may influence the outcomes of transplant. And this is especially important because of the gaps that we observe. Like sometimes we have very good short-term outcomes, but later on we have chronic rejection and graft loss. I know we are very much aware, we have a lot of experts in the room, we are very much aware of the role of HLA gene cluster, and this is a cluster that has been really been focused when it comes to transplant, mainly because of the interaction of these antigens with the immunological profiles that we have. And so when we have mismatches in these genes, we expect or we might have treatment outcomes that are low or rejections. But also the field of genomics has been evolving, and now we are starting to see the use of pharmacogenomics, which is really trying to understand how genetic information may help us to understand how the genetic pattern of a person may influence treatment outcome. So in this case, transplant outcome. So there might be a set of genes that a patient is carrying, or even a donor is carrying, which may interact with the system, because we know genes interact with other genes, directly, indirectly, in so many ways. So we might have a set of genes that actually influence how the transplant outcome may be. So when we talk about HLA genes, we have three classes, major classes, and these genes are actually inherited from both parents, mother and father, in a codominant fashion. And these genes are known to be very diverse across populations, which means that you may have a lot of combinations, haplotype combinations that may be inherited from the parents to the offspring. And this means also you may have different degrees of matching, which translate into different degrees of how the transplant outcome will be. So some of the combinations may lead to rejection following transplants. So these classes, why are they important? This is because they interact with different characteristics or different parameters within the immunological profile of a person. So you see, for example, class 1, which have HLA A, B, and C. They interact with lymphocytes and CD8+. While class 2 interacts with CD4 and lymphocytes. And you see that class 3 interact with cytokines. So you can see that they are actually variable and they interact differently with the other cells in the body system. So in summary, as I said earlier, the different matching between the donor and the recipient in these genes that we have, or these HLA clusters, may also translate to different degrees of the transplant outcome. So you would see, for example, matching or mismatching of the class 1 antigens has a lesser effect on graft survival unless there is also a combination with the matching from the class 2 antigens. And again, it depends on the kind of transplant that we're talking about. If it's bone marrow transplant or organ transplant, is it kidney transplant or liver transplant? The different degrees of matching translate differently in terms of the outcome of the transplant. I also want to highlight that although we talk so much about HLA, genetic variants, we also need to understand that there are also non-HLA variants that are really important when it comes to transplant outcomes. So for example, in kidney, we have APO1 gene, which is a key modifier of kidney disease. So people of West and Central Africa tend to have different genetic variants in these genes, and some of the combination of these genes make someone at a higher risk of developing a kidney disease. So you may think, for example, that you have screened the HLA genes and you have a good match, but the donor might be carrying another variant in these which affects the kidney life. So the outcome of the transplant might be good in terms of the matching with HLA, but then the safety of the organ itself is not that much if this person is carrying other variants that may affect the organ life or organ safety. We also have another example, KR interactions, and this is very important because these set of genes interact with HLA genes. As I said before, genes interact with other genes in so many ways and influence how the transplant outcomes are. So the message here is not just to focus on HLA genes alone, but also to focus on other genes that may also either interact directly or indirectly with HLA and other immunological profile and lead to different outcomes of the transplants. Pharmacogenetics, as I said, this is a very evolving field, very applicable in terms of genomics in medicine. And we have examples of how developed countries have started to utilize genomics to guide them in terms of immunosuppression strategies. So, for example, for these two drugs, tacrolimus, I believe we have experts who know better how they actually administer these drugs. But from a genetic perspective, we have genes that actually influence how this treatment is taken up by a person. So some of the variants may lead to a very poor response to immunosuppression simply because they are carrying genes that either make them not to metabolize this particular drug very well, or the different doses may apply to different people based on the kind of genetic makeup they have. And this is also important economically because we might be, I think I heard Dr. Stella talking about the cost that is put into buying some of these drugs or some of these reagents that are required for the transplant. And if you want to put so much money, I think it's high time we also think of how we can utilize genomics to guide us, whether this person may actually respond well to this immunosuppression strategy or dose of a drug or not, rather than using that and then you expose them to side effects, adverse reactions, but also the budget. On the other hand, pharmacogenomics also helps us to, one, identify biomarkers that we can use to monitor response, but also we can use the same information to develop drugs that are much better. My time is up, so I need to rush, which we really need now because we all know the current medicine is not just one size fits all. So at the moment, we have a number of emerging tools that are coming up from genomics applications, and the cost of the technology is coming down every day. So one of the things that people are now doing is seeing how they can integrate whole exome. This is screening throughout the whole genome in genes that code for important proteins and see how these may actually influence treatment outcomes. And then developing risk scores that may guide and say whether this donor-recipient match will work. And then having bioinformatics pipelines that may assist in predicting response. And then we have heard about gene therapy. So gene editing is also being applied to correct some of the mutations or abnormalities in organs prior to transplant. So I was just thinking, how can we integrate genetics in transplant services? So I think we need, of course, to start from research. So we need to conduct population-specific pharmacogenetics research that may guide us on the kind of variants that we carry in our population. This is very critical because sometimes we are exposed to drugs that we should not be exposed. And then, as I said, HLA and non-HLA diversity, we need longitudinal studies that may document donor genetics and how this influence transplant, and then implementation research, which may guide us on how best we can actually roll out genomic services integrated into transplant programs. So I'm coming from MUHAS, MGL. We do HLA typing. We started with low resolution. We now have started high resolution, which is important for transplant like bone marrow. High resolution, of course, covers more loci from the HLA. And thank you.
Jamani, makofi tena kwa Dr. Nkya. Kiukweli ametupitisha kwenye mambo magumu lakini muhimu sana. Kuna wanafunzi wetu wa immunology hapa, yudo mnafikiri wamefaidi sana hapa kwenye hii topic. Okay. Our next presenter is Dr. Deogratias Soka. Dr. Deogratias Soka will take us through community awareness program. And who is Dr. Soka actually? He's a public health leader over 19 years. He has been working, exercising in clinical research, training, and advocacy in non-communicable diseases, and particularly in sickle cell diseases. He serves as an executive director of the Tanzania Sickle Cell Disease Alliance. Kwa lugha fupi ni mbuyu umesimama hapa. Karibu Dr. Soka.
Thank you. Thank you. Let us imagine of a child born in a rural district in Tanzania with sickle cell disease, and this child is not diagnosed. And by the time this child is referred to the tertiary facility, after getting sick repeatedly, this child has already have a lot of complications that this child cannot benefit from curative treatment like bone marrow transplant. And then let us imagine of another child born in another rural district, in Tanzania, and this child is diagnosed at birth, linked to care, and gets an opportunity for curative services, curative treatment like bone marrow transplant. The difference here is not technology. The difference is organized, functioning community systems. Good afternoon, ladies and gentlemen. I would like to take this opportunity to thank the organizers, Benjamin Mkapa Hospital, for giving me opportunity to speak to this very important symposium of organ transplantation. The title of my talk is going to be From Community to Cure, embodying community systems in Tanzania's bone marrow transplant roadmap. I wouldn't repeat about the burden of disease because the previous presenters have spoken a lot about the burden of this disease. So for the interest of time, I'll jump this, but we should always remember one impact that is not talked a lot about with scientists, the impact, the socio-economic burden of sickle cell disease. My friend from NHIF jumped the slide, I saw the slide, which was showing the cost of taking care of a sickle cell child per year, annually, which ranges from 3 million to 10 million annually, direct and indirect costs. And this is very important to consider when speaking of communities. Now, as TSDA, what are our impact areas? Our areas of impact are mainly 4: community awareness, policy advocacy, strengthening the services, and early infant diagnosis promotion. And when it comes to awareness, we use all sorts of platforms to make sure that the awareness about sickle cell disease reaches most of our people in the community. So we go all the way from public, schools, community leaders, commemoration of World Sickle Cell Day, using of the all sorts of media, all the way from mainstream media to social medias, to ensure that the awareness about sickle cell disease increases, because one of the big challenge about this disease and other diseases is the awareness about the disease. When it comes to policy advocacy, we've been able to achieve 3 things. One is inclusion of sickle cell disease in the NCD strategy. As you can see, the national NCD strategy, previously the sickle cell disease was not included, but now sickle cell disease is included in the NCD strategy. Another thing that we've been able to achieve, we don't have a policy, but there's a call for action about sickle cell disease. And importantly, is the call for action on screening of all infants at birth in all district hospitals, which happened like 3 years ago. And this is a call for action. Now we are working to see if we can change this into a policy. Another important call for action is recognition of sickle cell kama janga katika Tanzania. This is very important when the disease is recognized. But another very important call for action is the call for action for our youth and adolescents to screen to know their sickle status. The advocacy continues. Last week we had a meeting with the committee, the Bunge Committee for Health, trying to get buy-in and push the agenda of sickle cell at the policy level. Yeah. When it comes to strengthening of sickle cell services, we have done 3 things. One is ensuring that the treatment is standard, so sickle cell management guideline, and now we are speaking of the 3rd edition. We had no any guideline 10 years ago, but we were able to have the 1st edition, 2nd, and now we have the 3rd one. We have the sickle cell passport, which is a booklet for all sickle cell patients, and this has been adopted by the ministry so that every patient with sickle cell disease can be recognized, and we keep all the important information in this booklet. But very important for the practitioners, we have a desktop guide which guide clinicians when they are seeing patients on, and this desktop guide has all important information that a clinician might need immediately. We are very much involved in training health workers at all levels of care, all the way from regional referral hospitals to dispensary level, to the primary health care level. And then another thing is about establishing sickle cell clinics. 5 years ago, we had the only 5 clinics, sickle cell clinics in Tanzania, but now we've been able to advocate for initiation of clinics in all regional hospitals, so more than 90% of regional hospitals have sickle cell clinic. And good thing is now we have clinics to the level of district and the health center. As you can see, one of the clinics in the very, very far part of Tanzania, Shirati, which is the northern western part of Tanzania at the border. We have a clinic there at Shirati. But 2 weeks ago, we opened the clinic at the regional level in Singida Regional Hospital. So the sickle cell services are ensuring that the services are taken to the people. But of very much importance is inclusion of patients. We call our sickle cell patients warriors. So we are organizing patients. We organize them into groups, and they are forming their patient groups. So we have different patient groups. We have a Bone and Blood Foundation. We have Sickle Cell Patients Community of Tanzania, Sickle Cell Family of Tanzania, Tanzania Sickle Cell Warriors, which is based in Mwanza, and Sickle Cell Youth Foundation. Critically is data and registry. So sickle cell, the sickle cell module is not in the GOT homies. But now we are working with TAMISEMI, and we are on the final stages of ensuring that the sickle cell module is included in the GOT homies. So before the commemoration of World Sickle Cell Day, which is 19th of June, we are going to launch this module in the GOT homies. About newborn screening, newborn and infant screening, what we've done is to make sure that there's a protocol for this. Because when you give a call, how are people going to be screened? So we've been able to develop a protocol for early infant screening, and this protocol has been included in the treatment guideline and has been signed by the CMO. Another thing which is very important when it comes to early infant screening is inclusion of sickle cell testing in the booklet, the card, the antenatal card. So this is something that's ongoing right now. We are working with RCH to ensure that the sickle cell testing is included in that booklet for under fives. So screening is ongoing, and now we are proud to say that we are doing screening not only at the regional level, we are doing screening up to the primary healthcare level as for dispensary and health centers. And as you can see, this is one of the center in Geita, the health center in Geita, Katoro, where we are doing screening for sickle cell disease. So this is a massive achievement. Finally, I want to finalize by saying that we need community pillars if we are to run a very successful bone marrow transplant services. So number one, we need early identification for newborn screening and community referrals. We need trust and acceptance. We need to address myths in our societies, and we need donor awareness, and if possible, build a culture for donation and engage the young people who are the potential good donors. But lastly, we need a very long support in terms of psychology and adherence to systems. My final slide is just by thought that the roadmap to bone marrow transplant in Tanzania will not be built in the operating theaters or hospitals alone. It will be built in communities. Thank you very much.
Yeah, I hijacked the program. Allow me, dear moderators, to make some adjustment on the program. We will take a break for lunch, and you will be assisted by our ushers, line by line. We don't want you to queue for a long time, and the serving areas are the same areas where we had our breakfast. I'm asking that we take our lunch very quickly, within 30 minutes, and then we'll come back. When we come back, we'll have a panel discussion and a few presentations, and then we'll kick on our closing ceremony, whereby every participant will receive a certificate that is worth 80 CPD points from the Medical Association of Tanzania. I ask you to observe all these requirements so that we are all on the same page. We will have a presentation from South Africa. We'll have a presentation from Japan, and then we will have some presentation from the two presenters or three presenters who are here. Then we'll form a similar panel of 6 people, including Dr. Fabio and Dr. Babu and Dr. Asimwe. And then we'll take 5 minutes break, then hear the other transplants from cornea and referral pathways, and then we'll be calling it a day. I assure you, within the next 2 hours after our lunch, we'll be done with the conference. You'll be able to catch up with many things that brought you in Dodoma. Thank you very much, and remain seated until when they raise you up. DJ or our colleagues who are playing instruments, please continue giving entertainment and pictures, showing pictures and many other things as we go and walk out for lunch. Thank you very much for your attention. Thank you very much for your cooperation.